Alvin is calling in from the Philippines. He is from the Asian eHealth Information Network. And Alvin, we are happy to listen now to your Asian perspective on global digital health.
Thank you, Jürgen. Good morning, everyone. Good afternoon and good evening, depending on where you are. I'm Alvin Marcelo. I'm from the Asia eHealth Information Network, and I'd like to share our experience over here. Thank you, Jürgen, for the invitation. I think I'm seeing what you're trying to do. You're trying to bring all of the people around the world that you know who are doing similar things and start working together. And on our side of the world, the Asia eHealth Information Network, is happy that we've encountered people like you, the previous speakers, who are also doing similar work, and we look forward to working together with you. So we are a nonprofit, non-government organization in Asia, operating starting with 7 countries and now over 25, starting with 6 people and now over 1,800 individual members. We are a collaboration of advocates from South and Southeast Asia committed to promoting interoperability for better health. And our problem statement when we started way back in 2011 was we all wanted universal health coverage, and we all knew we needed to have interoperable systems and data sharing to achieve UHC, but we did not know how to do that. And over the past 10 years, we realized that we will only achieve interoperability when our governments lead and if our civil societies support. And I'll elaborate more on that in my subsequent slides. So we formed AeHIN from 7 people to 1,800 individuals with a vision of strengthened interoperable digital health ecosystem for better health in Asia, with the mission of promoting learning, resource sharing, and knowledge exchange to strengthen digital health throughout the networking approach. And we identified 4 strategic areas that we would work on. The first is to promote leadership and governance for digital health. Second is facilitate capacity building for digital health. Third is to create opportunities for knowledge exchange and resource sharing. And finally, enable interoperability through standards. We have 5 council members and a secretariat operating in 4 countries. But the structure is that our members are at the top, they form the General Assembly, and we have identified 2 to 3 people per country who we call the Working Council members, who give us advice on what to do and what strategies to take for the following year. We are the governing committee, and we are led by an executive director, and we have communities of practice who I'll describe later on. Annually, we hold general meetings. So this is our biggest event. We started our first one in 2012 in Bangkok, and our latest one is upcoming November 6 to 9 in Jakarta. We always hold our general meetings co-hosted by the Ministry of Health of the host country. We started with webinars using GoToMeeting, WebEx, finally moving to Zoom. We've had 297 since the beginning, a total of 9,000 plus cumulative, covering different topics. Anything that concerns our members, ministries of health, other ministries that have achieved some success with any digital health project, we feature them so that our members will learn more about how other countries are doing and dealing with their problems and how they're solving them. We create an ecosystem of sorts with government, academe, and non-government organizations coming together to support the government with their digital health initiatives. So to summarize, we've uh, collated the knowledge of our members over the past 12 years, and we saw what we call are the gaps in digital health in our all our countries, and we summarized the gaps to also be GAPS. G would be governance, A would be architecture, P would be people and program management, and S would be standards and interoperability. And our message to our members is mind your gaps. Make sure that you have covered your bases when it comes to the GAP and S, And we have started collating the knowledge base of our members and showing them how other countries are actually filling in these gaps. And we summarized our call to action as follows. For the G, or governance, we are encouraging our governments to institutionalize a sustainable, inclusive, resilient, and collaborative digital health governance structure. We think digital health entails a lot of decision making and big major investments, and only people in the right positions in government can make these key decisions, and they can do that through a clear governance structure. On architecture, we think that the first important decisions of the government is to share an integrated and standardized digital health blueprint to all stakeholders. This blueprint should be aligned with the national health and digital visions and strategy of the country. That makes it very clear for everyone in the country on what we are trying to build. Then we talk to the builders. We need to have good program management, make sure that we have good digital health transformation offices or collaboration offices where they are needed, and we need to address the needs of our people, our patients, and our healthcare providers, make sure that they have the proper digital health literacy so that they can make the best use of the applications that we are offering to them. And finally, we need to give them the building blocks, the standards that we need to achieve interoperability. So we put it all together from mind the gaps or paying attention to your governance architecture, program management, and standards. And what do you do now to fill in your gaps? And we have created together with WHO, ADB, and UNICEF a program called a Convergence Workshop. It is a Ministry of Health led event where we gather support from public and private sector stakeholders to put their support behind the national e-health strategy. And with this, it's basically a 2 or 3 day conference. The Ministry of Health is the convener, and we invite private and other government agencies to understand what the Ministry of Health wants to do when it comes to health and digital health, and how they might be able to support the Ministry of Health. And here, AeHIN supports by designing the program, sharing the templates of other countries, inviting resource persons from other governments, and also doing facilitation of the breakout groups in the actual conference and workshop. And the outputs are very, very good. At the end of some of these convergence workshop, they now have a clear governance structure within government, with the Minister of Health chairing the multi-sectoral governance structure, and other ministers supporting the Minister of Health. They agree that they should come up with a blueprint. Some of them recruit a professional architecture company to help them with the blueprint. Some of them engage development partners to support the blueprint development process. Then they shift to program management. They create capacity building programs, engage with the academe, make sure that they have the right capacity building programs to have the right people to build the blueprint, and then they acquire the standards that they need. We've been conducting these convergence workshops since 2015, starting in Myanmar, and our latest one was in Jakarta last January. And so all of these we're now calling our GAPS 2.0 version from the first version that we launched in 2017. And the call to action will be released as a paper soon, latter part of the year, and will be formalized in our general meeting in Jakarta this November. To support the capacity building needs of our members, we've given and provided support, of course, with the help of WHO, USAID, ADB, and UNICEF, to members of governments from our member countries on HL7, TOGA for enterprise architecture, COBIT for IT governance. This is consistent with our strategy to support the needs of our members. Recently, we've been providing free training on HL7 Fast Healthcare Interoperability Resource, or FHIR. A lot of people have attended these free trainings. After they attend this free training, the ones who perform well, we support financially by taking an official HL7 course with the HL7 International Education Program. And from this group, we encourage them to undergo certification. And if they do pass the certification, we reimburse them the cost of their certification fee. So essentially, it becomes a free certification process for them. So by following this stepwise approach, we build confidence amongst our members so that they finally end up being certified on HL7 Fire, which we think is an important interoperability resource for all of us in the region. So now we bring in all of this knowledge sharing, capacity building, and resource exchange. We mix them with existing standards like ICD-11, SNOMED, and HL7 Fire, and the result is a set of people or a community of practice. And we have two of them. These are special interest groups of AeHIN members helping each other help their countries. The first one is called the AeHIN Regional Enterprise Architecture Council for Health. These are our architects. They passed the TOGAF course. They got certified in TOGAF. So we ask them to consult each other and help each other if they have questions about architecture. And this is the group that has consolidated our knowledge into the Open Health Information Exchange Framework and HL7 Fire. And then we have the builders. There's another community of practice called the Community of Interoperability Labs, which is the topic of my talk. These are research units either in academe or in the Ministry of Health, but their goal are the same. Their goal is to build capacity to use existing standards, existing blueprints, and achieve interoperability. And here we have identified the 5 T's that we need to do as an interoperability lab. First, we need to do teaming, basically bringing together all the stakeholders needed to come up with a national standard or an international standard. The second T is tooling or creating the tools. And here I think IHE will be able to help us very well. The third thing after the tooling is that we need to train the people on how to use the tool, whether it is an API or whether it is a new module in an electronic medical record. The fourth T is testing to ensure that the tools are actually working and we're able to exchange semantically consistent data across each facility. And finally, if the tests pass, then we transfer to the government so that they can start promulgating and mandating the standard. We have labs in the Philippines, Thailand, New Zealand, Taiwan, and Sri Lanka. And we are now helping Laos, Nepal, Hong Kong, and Vietnam develop their own standards and interoperability lab. So to answer the question, how do we create interoperable systems to support universal health coverage? So we adopted the enterprise continuum framework of the open group architecture framework. So we looked at the global perspective, selected an international standard, and then met as a group of countries to gain regional consensus on what standard to use. And then finally, after we've agreed on that regional standard, we encouraged each one to extend that international standard to the national. And what did we choose? We chose FIRE, International Patient Summary, as our international standard. That became a consensus. And we will announce this in our November general meeting, Jürgen, in Jakarta, that the base profile for the region will be IPS. And then we encourage each member of the community of interoperability labs to then extend the IPS for whatever use case is relevant for their own country. And here, for the Philippines, for example, we had a meeting yesterday with James Agnew and with the Ministry of Health, and we all agreed that our first use case, which is relevant to the government of the Philippines, is nutrition and tuberculosis. And then we would extend IPS for that, and then we would add more use cases. And we expect the same process to follow from all the other labs in the community. The nice thing here is that because we all started from IPS, then there is always that common base or ground for international exchange of data in case we need to do that. And I know that the Indonesians are very eager to also adopt IPS. They're looking forward to also using this as a framework during the Hajj when the Muslims visit Mecca. So finally, we'd like to invite you to our general meeting this November 6 to 9. Our theme is putting blueprints into practice. We have 4 countries now that have published officially their enterprise architecture, and they've now put this enterprise architecture or blueprints into practice, and we'd like the other countries to listen to these 4 countries and follow suit. So that will happen in Jakarta this November. The link is at the bottom. I'll share the slides here again to share to the rest of the audience. So finally, to answer the question, what do we need to do to achieve interoperability? I think we need civil society to support the government's digital health initiatives. Government cannot do it alone. Civil society cannot do it alone. They need to work together, and that's what AeHIN is all about. We are civil society supporting government's digital health initiative. Thank you, Jürgen. Good morning, everyone.